Oh, hey, Chris.
Hey Chuck, how are you?
I'm really, really good. It's a special night.
It is a special night. I think I would have to say our favorite recurring podcast guest is with us tonight. So it's gonna be great. Macy's back.
Macy's
Hey,
back.
I'm happy to be here.
We not as happy as we are because I think, when you're on an episode, like listenership goes through the roof.
I don't know if you're just being polite or if that's actually true, but I'll take it as a compliment. So thank you.
You're gonna have so many people recognizing you when they see you at the hand therapy meeting in St. Louis later this fall. They're gonna
I
say,
don't
"That's
know.
Macy." It's gonna be great.
Or on the street. I mean, people may just walk up to you and say, I know you.
Well, thank you. That'll be interesting. Okay, let's get moving.
But Chuck's just like
Let's
tired of
let's
talking to me,
let's
so
not.
Before we jump in with Macy, we did have a podcast listener write in about our partner Ryan Nunley and I guess I would say like fanboy discussion of his efficiency and of his practice. Um, and there was some concern that maybe we were overhyping it. Maybe we shouldn't be promoting practice efficiency. I don't know how you heard it, Chris, but I'd love to hear your thoughts about the concept.
yeah, no, I wasn't as pessimistic about the comment, which we certainly appreciate. I think that it's not that I think we're overly enthusiastic about it, and perhaps maybe we just should have provided, some more context that there's definitely a lot of different ways to run a practice. Having a waiting list for surgery for 6 months is not ideal in terms of, having to make people wait, et cetera. And folks should be able to get the care that they want slash need perhaps earlier. But I think there are a lot of good things about the way that Ryan has structured his practice. And anybody that knows you knows that, like I said, your love language is efficiency. So, I mean, if you are able to find ways to just make the most and, out of the time you're at work, it means that you can make the most out of the time you're not at work. And having recently spent even more time with Ryan since the podcast recording, he lives it. And he's there with his kids. Actually, my son had a sleepover at his house just this past weekend, and he was fully doubled down and was hanging out. And so he's not always on the phone doing stuff when he's not at work. So I'd say I think there probably is just room for some more context. No, there's a lot of different ways to do things. But I'm of the like where if I'm at work, I want to be as maximally efficient as I can, so I can not have to worry about that stuff when I'm not quote at work.
Yeah, I think that's right. And we recognize that those choices are not for everyone, and we're not here to say how to run your, practice in your life. But I think a good example was a couple weeks ago I had a case cancel, a big case cancel, and so my day was not like filled to the kind of maximum extent. And so when that happens, I think all the listeners will know what tends to happen in the OR is that everything slows down. And so that's fine if mentally I'm going to be there till 5 or 6 because we canceled the case. And I'm not going to get home any earlier. Or you sort of have the mentality that, look, we push like we always push. And if we get done an hour early, fantastic. And that's my mentality because the time I spend at work is the time I spend at work and I'm not at home. So that's why I am passionate about efficiency.
Right. And it's like, I remember when we would do these big Plexus cases early on and Marty Boyer was around. He would come in and he'd say, look, we got to keep moving. This case will take as long as you give it. So a lot of times, stuff at work can be like a sponge. It'll expand to fill the space. So, I like the ability to get things moving, get things done, and work at a high clip so that you can, again, focus on other things. There was one comment in that email about the Nunley episode I thought was interesting about, how would you feel if you were that patient's, 12th, or if you were that surgeon's 12th total joint of the day or whatever. I don't know. Oftentimes when I'm kind of late in the day and just stacking all my locals at the end of the day, I do have patients ask me how many surgeries I've done that day. How do you answer that, Chuck?
Um, it is a fair comment. I answer that question. I don't. Sometimes I tell the exact number, but I think it's a fair comment only if we let our fatigue show or let our fatigue affect our ability to provide every patient the same excellent surgery. And I had a big case then today. I had a really big case. It was a massive OCD, and we were treating it with a graft. And I think I get energy towards the end of the day, to be honest. But it's a fair question, and I think if I get to the point, I actually said to my wife when I got home that I feel like I'm getting older because when I get home, I am tired. Um, then I need to cut back because if I can't give that last patient the same attention I give the first, then shame on me.
Yeah, I think it's absolutely fair. So we've kept people waiting too long to talk with Macy. We have to make them wait a little bit longer because we do have to thank our first sponsor. The Upper Hand is sponsored by PracticeLink.com, the most widely used physician job search and career advancement resource.
Becoming a physician is hard. Finding the right job doesn't have to be. Join PracticeLink for free today at www.practicelink.com/theupperhand.
Yes, PracticeLink's also exhibiting at the WashU Nerve course, which will have just completed by the time y'all are listening to this. So thank you to those of you that waited outside in the rain to get into the WashU Nerve course. I'm sure there were a lot of people that couldn't get in.
You know what? I actually looked at the lineup for the first time this morning, carefully. It's awesome. It's a really, really good agenda. So congrats in advance. And I hope and I know everything's going to be pulled off perfectly.
We'll look forward to it. So Macy, thank you for joining us again today. I think we had a really good discussion, Chuck and I did last time about finger fractures and how we approach things. And I think finger fractures are some of the more challenging things that that hand surgeons and hand therapists can treat just because there's so much variability. So tell me, is there one particular pearl that you can give us to open up?
You know, before this started tonight, I reminded you that we did a similar podcast a few years ago, and my commentary has changed. And I think that a few years ago you asked me which would I rather rehab, pinning or plating, and my answer was pinning. And nowadays, whenever I see pinning, I kind of, oh no, because I've realized in time that I prefer plating. Interestingly, because it's changed. I've just found recently that people get scarred in or they get freaked out by the pins more. So I think I've just kind of changed my preferences for rehab for plating. But I don't have any pearls in general. I guess it just depends. Like that arthritic patient who wants to get back to farming versus the kid who wants to get back to sports. There's just so much variability. So I feel like it's hard to answer without like a case to talk about or
Yeah,
something like
yeah,
that.
thank you. We should do that. Maybe we'll start proximally, work distally,
Okay,
um, and throw out a couple different cases. So if it's
perfect.
okay, I'll start with a case. Um, I have a 23-year-old male who has two displaced midshaft metacarpal fractures. And Chris, why don't you jump in first saying what you would do, and then we'll ask Macy what she thinks about your choice and then how she would rehab it. And so these are displaced, they're unstable. I'll say the fifth metacarpal is at 45 degrees shaft, and the fourth is about 40 degrees. So markedly displaced, 3 days old, hands pretty swollen, no numbness or tingling. What's your conversation with the patient, and how do you think you would proceed?
Well, yeah, first I'll ask what was the name of the girl, because typically this is preceded by some kind of hand versus stationary object such as wall. Actually, the last time I asked that, which was in clinic this week, he's like, "Yeah, I was mad at my mom." So, okay, fair enough. But yeah, so you're painting a picture of a patient who's probably indicated for surgery. I will say that although the textbook and ortho bullets and all of them say that multiple metacarpals is an automatic indication for surgery, it's not always. I have treated some patients with multiple metacarpals non-operatively and been satisfied with that. I think it honestly depends on the situation. You did not mention whether there was any sort of rotational deformity or not. I'm assuming, maybe there isn't one, but that clearly is one that would sway an indication towards surgery. 23-year-old, you said, probably somebody that's in the prime of their earning and is trying to provide for themselves, family, perhaps. Um, I think honestly, the most predictable outcome does come with surgery. It's just a question of how to provide that stabilization. Mid shaft, fourth and fifth. Honestly, my go-to now is probably headless compression screws to provide the stability, the upside of the stability that Macy mentioned, without the downside of the potential downside of tendons adhesing to the plate, et cetera, and less surgical trauma. So that's where I'm now. That's probably not where I would have been when we started recording this podcast 18 years ago.
That's true. 18 long years ago, we started this podcast. Um, Yeah, I think it's a fair statement. We wouldn't have, neither of us would have likely chosen headless compression screws, intermedullary screws. Not that there's anything wrong with plating or even pinning sometimes. I think we've all grown accustomed to the benefits. So, Macy, are we as surgeons making a good choice by choosing the intermedullary screws? Are you seeing a lot of those patients, and do you have to continue seeing them, or do they seem to do pretty well?
Think they do fine. I think I would, categorize those patients in between, like you mentioned, plating and the pinning. So, I think that's actually something that I would really prefer to rehab actually, because they're not so freaked out from the pins, which most people don't do range of motion while they see them because scares them, and then they don't get so adhesed to tendons, like you said, with the plates. So I think, yeah, that's a great option.
So,
It,
So what do I do with that person?
yeah, what do you do? Well,
Uh,
sorry.
okay, yes.
When do you want to see them? How do you tend to provide a mobilization, if you provide a mobilization? And what are your instructions to the patient as far as home therapy?
So if they're in a dressing that's pretty supportive and their MCP joints are flexed well, then I'll probably see them between a week and a week and a half, something like that, maybe 2 weeks at the latest. And I want to ensure a few things. I would put them in a hand-based ulnar gutter splint with the ring and small finger. If they're younger or not really trustworthy, I might include the middle finger too, just for additional support. And I want to ensure that the MCPs are in a good flexed, closed pack position with the IP joint. Oh, wait, hang on. IP joints I would actually have free. I would have those exposed. Um, just because it's a metacarpal fracture, so those should be fine. But the MCP joints are included. I want to look out for two things. I want to prevent MCP capsular stiffness, so being able to work on active flexion, because a lot of times those get really, really tight from collateral ligament shortening. And then I also want to look out for like tethering of the EDC along the metacarpal, so extrinsic tightness. So those are the two problems that I would want to watch out for. And on that first visit, I would obviously make them the splint and do wound care, etc., but give them active range of motion, which would look like, is this video recorded? Can people see me?
we can
Okay.
Yeah.
see you.
Okay. Okay. So I would have,
YouTubers rejoice.
okay, great. I think one time I did this podcast, I didn't know that, and I just got out of the shower and my hair was soaking wet, and you were like, okay. Anyway, so I would have them work on like active extension, composite extension, working on it, what's called a tabletop. So full MCP flexion with the IPs extended. That's often very difficult for them. I don't want to work on hook fisting, which is just the IP joints flexing with the MCP joints in extension. We're just going to really work on EDC excursion, going back up to full extension, and then working on a full composite fist. Sometimes I'll work on abduction and adduction as well, but just like a very basic introduction to active range of motion day one. Then I'd have them come back and see where their deficits lie. Is it EDC scarring? Are they having a hard time with engaging their long flexors? Is it, scar tissue adherence or dorsal swelling? What's the problem? So
So is
I
that a
could, I could,
couple?
I could keep going on. You got to stop
No,
me.
I have a couple questions. I mean, so
Yeah.
is that the same protocol you would use regardless of whether that was fixed with the
Yes.
intramedullary screws or with a plate?
Yes. The only thing that changes my mind necessarily is when to initiate active range of motion, and what sort of deficits I'm anticipating.
And then why include the MP joints in the splint if
If
when
it's a
I've
shaft,
yeah, when I've done this for shafts that I've put intramedullary screws, I actually go with a metacarpal cuff,
cuff,
MPs, fingers completely free. And the cuff
wasn't
may
he?
is probably overkill. It's probably just a reminder like, hey, don't do something crazy.
So, whoa. So you would have been fine with no mobilization?
Honestly, for most of these patients, if I really like the stability, yes, if I trust them. But I give
Okay.
them the cuff as a reminder.
Um, I guess like he's 23. I don't know. More rather than for protection, more so for positioning,
Okay.
because when they're without the MCPs in any flexion, they're gonna be kind of in extension pretty much all the time. So I would use it more so for keeping the collateral ligaments stretched out. and avoiding them tightening up into MCP extension. That would be a decent rationale for that.
Yeah, that's great. I'm just curious because I mean, I guess as a surgeon, I tend to protect a little bit more in most cases. And I think this is one of the cases where I'm a little more liberal.
Yeah, that makes sense. I think there's a case for both. I guess I would have to feel around for the patient's personality and see if they seem likely to comply versus not.
Yeah, I have a younger population in general, 23-year-old male who punched something to sustain these fractures. I would want a brace of some sort of splint, orthosis, whatever we call them these days. And I do think a cuff has a lot of value, the metacarpal cuff. And for those of you who don't know the terminology, it literally just comes on the ulnar side and spits across the dorsum mainly, but also the palmar aspect of the hand. Obviously, it leaves the MP joint free, so that's different than what Macy was suggesting with immobilizing the MP joints. But you're right. I mean, with intramedullary screws, I don't really worry about tendon adhesions too
Mm-hmm.
much. It's
Right.
really the capsule that I do worry about, at least a little bit. But it's been pretty rare that I've seen issues. But I do send patients to you guys, and I think they all are treated as you suggest.
Now, how often are you seeing patients treated with pins? And, how do you counsel patients through telling them that it's okay to do some motion, even though, like you said, they probably aren't doing a whole lot?
Yeah, I don't scare them, but I just kind of say, hey, look, like I recognize that this is, difficult to see something protruding from your body. And I've seen people get quite stiff, and I don't want that to happen to you. I promise I would never give you an exercise that's going to harm your recovery or impact the integrity of your fracture fixation, and just really give them confidence that what I instruct them is okay and very much encouraged to do frequently. And I just see with pinning a lot, anecdotally speaking, I guess, just um, lack of motion and like as opposed to capsular stiffness, more like yeah, flexor tendon adhesions, I would say. And honestly, my brain right now is going to like P1 fractures, not necessarily metacarpals, but that's just where my brain went.
Yeah, let's keep going because I think in general these fractures, metacarpal fractures, do well.
They do.
And I think the intramedullary fixation is even more reliable, and we are less at risk for seeing some of the complications. Proximal phalanx fractures,
Well, hold on. Can I ask a question before you end this part of the
for
conversation?
sure.
One comment and one question. So I guess I would just caution that I think the intramedullary screws are great, but they're not a panacea. And we still don't know. We know a fair bit about how much of the cartilage is compromised, and that it's not an essential part of the compromise or essential part of the articular surface that's compromised. Tendons tend to do pretty well from some early studies, but these can be really challenging if they get infected. There are some case reports floating around of the challenges that come about if one of these were to get infected. Now, fortunately, that has not been my experience yet, but I always think about that before I put these in. And then my question for Macy is just in general for metacarpal fractures, when can you start doing some strengthening?
If I communicate with the surgeon, which I'm very grateful for that communication and collaboration where I work, and I'll say, hey, how do you feel about this fixation? And they're like, oh, it's solid, which is typically what they might say. I would say 8 weeks. Does that seem reasonable?
It just seems longer than I would have
Oh, you seem
expected, to
late.
be
That
honest.
seems longer.
Again, I'm usually very conservative on
Oh,
some of
that's
these things,
funny.
but I would probably
Okay,
think that they could be doing,
six.
if they're moving. I usually tell people if they're moving well, I get them started in strengthening in 4 to 6 weeks, as long as they're not tender over their fracture site and there's no sign and everything looks okay on the floor scan images.
Honestly, this is really good for me to hear and to learn, that in this particular case, like you feel very comfortable and confident in the, stability. So this is actually a great learning opportunity for me.
Well, and I think a couple of things. One, I see my patients at 2 weeks and 6 weeks, and then may not see them again, or probably the next visit would be 12 weeks. So if I send them back to you guys at 6 weeks, it would be for strengthening or any motion deficits. But I don't always send these patients for strengthening. And if they've sort of graduated, they have good motion, they don't have pain, they have good healing. I don't necessarily send them for strengthening. But yeah, I mean, if it's a transverse fracture with great fixation, that's one thing. If it's an oblique fracture where you're just not quite as confident, just a different situation.
Fair enough. Now, why don't we move on to a proximal phalanx fracture? Did you have one in mind, Chuck?
Sure, sure. I'm trying to think of a recent case that would fit the bill. Um, I had a this was a 27-year-old lady who had a fracture, which was essentially a long oblique proximal phalanx fracture that did enter the PIP joint. And
Mm.
so it was displaced enough that I was worried about both the joint and the alignment. I think it was a torque injury that caused this, of some sort. Of finger was grabbed, and so she, is swollen. I think she was 4 days, 5 days out when she first came to the office. But a fracture, which I think anyone looking at the X-ray would be concerned about, both for healing the joint and her rotational instability. So, Dr. D, what do you think?
I always get this pit in my stomach when I see proximal phalanx fractures for the most part. With the exception probably of like the, metaphyseal base type fracture that's transverse. Everything else, you're never quite sure how involved it's going to be. And when you say long oblique, I've found that long obliques with this kind of mechanism tend to be more involved than the initial x-rays make you think. So you're telling me it's splitting into the joint. You're telling me it's a long oblique fragment or fracture line. I'm probably thinking open reduction and intramedullary, or not intramedullary, interfragmentary screw fixation. So multiple screws along the obliquity of that fracture, making sure to prioritize getting the joint right, getting the fracture out to length, and getting things stabilized. Temptation sometimes is to put that plate in. I think the way you're describing it, maybe it's too much for pins, but if you can get away with pinning, I think that that has a lot of value. And when I say get away with, I don't mean get away. I mean that you're going to get a nice reduction, good apposition of the fracture ends, and solid fixation with likely multiple pins.
Yeah, I think we'll turn it over to Macy in a second. I think all good points. Let's just carry the ORIF with screw fixation out a little further. For me, that means splitting the extensor mechanism longitudinally, typically 1.5 millimeter screws. I ideally would have three of those screws, but if it goes the way I hope it would go, it would be excellent fixation with good solid, I would have confidence in my fixation. So Macy, I'd like you to, and then we repair the extensor mechanism on the way out. So that's one scenario. The second scenario, I'm a bit biased by my partner Lindley Wall, and we do indications together, and she pens a lot of these. And so, especially in her younger population, she has a younger population than I do, but she will obtain an anatomical reduction, sometimes using a reduction clamp without incising the skin, and then put two or three pins obliquely across the fracture. So Macy,
I have found it a little bit challenging to get a nice percutaneous clamp down in some of my chunkier patients, so to say, especially with all that swelling there. So I was going to that with that being plan A, and I try it and I get a little frustrated. But when it works, it's fantastic. Do you ever, you mentioned splitting the extensor mechanism. Do you ever feel like you can dance around, on the side of the central portion of the extensor mechanism and kind of working in between that and the lateral bands?
I usually end up splitting it in some regard. Now, in this case, if I'm really worried about the joint, and I may not be, meaning I might not need to look into the joint, but there's any doubt about the joint reduction, I would go between the central and lateral slip, and truly split the extensor mechanism.
And how do you repair the split that you put in that mechanism?
Yeah, and I'd love for listener thoughts. I'd love for your thoughts. I usually use a 4-0 suture of some variety, Vicryl, sometimes monocryl. I don't know that you always have to repair it as long as your extensor is stable. We don't want that lateral band slipping over the side, is why I do repair it, especially if I'm going more distally. But I tend to repair it on the way out, but don't always.
And then do you lag those screws, or are they just purely positional screws?
I think I was biased by literature from long ago that basically says if you obtain an anatomical reduction, have a towel clip or a reduction clamp holding that reduction, then I do not feel the need to put a lag screw in. And I think it's really important, especially when one works with trainees. Lagging like at a 1.5 millimeter level can be very tricky, because if you're 2 or 3 degrees off between your 1.5 drill bit and your 1.1 drill bit, you can really cause problems. And so that's part of the reason I don't lag. And the other part is I think you already have compression from your clamp and you don't need it.
Right. The margin for error on these screws is incredibly, incredibly small. So, this is not one where you're kind of looking in a different direction while the drill is, in the hands of somebody else if you're choosing to have somebody else do that. All right, I talked enough. Let's hear what Macy thinks about if you've got, what the surgeon thinks is solid fixation with, multiple screws.
So just confirming this, it's not through the joint, right? It's just the fracture itself.
Along oblique fracture, the proximal phalanx stayed extended into the joint, but we got the joint perfectly aligned. We have
Got it.
3 really good screws. What are you gonna do?
3 really good screws. I'm feeling good. Like I'm feeling like I can move them 5 to 7 days. If that seems reasonable to you, I'm thinking this person is going to be in, which finger is it? Sorry, does it matter?
It was little finger.
Little finger. So hand-based ulnar gutter, MCPs in flexion and IP joints in full extension, including the ring and small. Trying to get that PIP joint in full extension is often the challenge. They want to be somewhat flexed, and most people end up with somewhat of a flexion contracture anyway. So getting them started 5 to 7 days, just with the same exact active range of motion program that I mentioned for the metacarpals, but with a little bit of a difference. For proximal phalanx fracture, which is like hand therapy bread and butter, these are the ones we see all the time because they get really stiff or scarred in. And so I would instruct them in blocking exercise. And for listeners who don't know what that means, it means supporting the proximal phalanx in MCP extension and isolating that flexion force only to the PIP joint. So you're not getting a full composite fist. It's purely just blocking the FDS to the small finger if they have one, and then blocking to the DIP in isolation as well, just to get more glide of those long flexors. And then I'll also instruct in what's called, this is very therapist lingo, but reverse blocking. Do y'all know what that is? Ish. So reverse blocking is for working on active PIP extension. So I start in some MCP flexion and I work on forcefully extending my extensor mechanism up into full PIP extension to prevent that long-term flexion contracture.
Which one's more important? And I think we got the gist. We probably could have figured out what reverse blocking was, but which one's more important, extension or flexion?
Oh, flexion by far. Flexion is function. That's what I tell my patients. And so people get really bogged down with a flexion contracture, like the inability to extend. And I'm always like, don't worry about that. Don't worry about that. Research shows that if it's more than a 30-degree flexion contracture, it's functionally limiting. If it's less than 30, it's cosmetic. And so I try to talk about the importance of flexion, flexion, flexion. With that being said, in my spiel is always that flexion is function. During the day, we really need to be working on active fisting and grasp and really getting your tendons gliding. But at night, it's a really good opportunity to wear some sort of static splint to keep that PIP joint in extension to help stretch volar plate, to keep your extensor in the shortened position. And then you wake up in the morning, take it off and work on flexion again. So that's kind of a common spiel I'll provide.
And I mean, Chris, I don't know if you have questions about that protocol or whether we ask about the pens.
I was going to ask about pins. I do like the quote that you had, flexion is function. I like that a lot. I think I may end up using that. And then you mentioned, about the 30 degrees being the threshold at which for flexion contractures where it's not, it's more of a aesthetic thing. It's really hard to explain that to patients in my experience. You tell them, like, at least for example, like in the elbow, you tell them the functional range of motion that we all quote, and the patient's like, no, I want my elbow straight. It's like, you don't need it. I want it straight. So it's very hard, I think, for patients to grasp that, at least on the brief interactions I have with them. So I'm trying to get better at my messaging, and making sure that I appreciate, yes, that they've got a deficit, that it appears to bother them. Because you have some patients who are so fixated on numbers. And, it becomes very, very challenging to counsel them away from trying to get a perfect score in the game.
Not being a number cruncher, I say that a lot. And you know what population just came to mind, and I don't want to talk about this, but it's the mallet population. They get so bogged down in the numbers and not being able to fully extend. And you kind of have to really coach them on like, hey, I hear you. I recognize that this stinks and this isn't perfect, but you're going to be okay. It's going to be fine.
Personal anecdote, I am recovering from a knee replacement. and I do think therapy is wonderful. I now believe in therapy. I was
You always believe
Wait,
in
you didn't believe
therapy.
in therapy before? Come on.
well, I will say the importance of a good therapist, and I was
Hmm.
fortunate to have a really good therapist, is really incredible. It gives the patient confidence. It is motivating. You don't want to disappoint your therapist. It's been an interesting ride. Of course, I canceled my last couple of therapy visits, but I'm doing pretty well. Um, but yeah, and I am not super focused on the numbers, but I absolutely can see why some would be, especially with the knee replacement. Like, how much flexion do I have? Like you just get fixated on the numbers. I get it. All right. Now, same patient, but instead of three screws buried, you have three oblique K wires exiting on the ulnar side of the proximal phalanx. What do you do with this patient? Do you want to see them at the same time frame? Would you rather us keep them a little longer before we send them down to you? What's your strategy?
I gotta be honest, my treatment for that person might not change a whole lot. 5 to 7 days would be great. I'm not really seeing these patients 5 to 7 days. I'll be honest, when I worked in the OC in Chesterfield, I feel like I did it. Where I work now, I feel like they kind of come at the 2 week mark after they get their post-op dressing off. And they do fine, but I'd like to see them a little earlier. Um, so yeah, 2 weeks at the latest, I'd say, for this
So your
patient.
your recommendations don't change, but probably what changes is their ability and or willingness to do what you're asking them to do. Is
Exactly.
that right?
Exactly. So with this person, they're just, I feel like they might be more swollen or freaked out, and their frequency of active range of motion at home is less. Um, and I'm thinking, again, anecdotally, that these get more like scarred in, like their long flexors can't glide. So like their fist might be like a 6 or a 5 to the DPC, but then I passively stretch them in and it's like a 1. So there's that big discrepancy between active and passive flexion, indicating scar tissue adhesions along their FDS, FDP, um, which is somewhat more of a challenge sometimes, just working on a lot of like active tendon glides, a little bit of resistance to challenge those tendons to glide further. Um, Personal anecdote, which I wanted to make sure that I said, not personal, but as a therapist for some certain patients, I've had maybe 2 or 3, maybe 4 patients lately that have had proximal phalanx pins get scarred in, have full passive, very limited active, and the surgeon has injected them for classic trigger finger. Perfect. Full
Huh.
motion, canceled all the therapy appointments because literally, I don't know what it is, but it's like now an experiment for me. I'm like, let's do a trigger injection, see how it goes. And they're like, good to go. How
So
interesting is that?
you would think that it's not for trigger symptoms, but do you think it's like the hydrodissection perhaps down the sheath that is opening up some of these adhesions if they're putting their injection in the sheath?
Maybe, I don't know. I think that like at least 2 of them did have some tenderness along the A1 pulley, so you could provide a rationale for doing it. I don't know. I really don't know. It warrants more people for doing this, but I think it is something that it's now in the back of my head, like, oh, let's try that. It can't hurt. It's better than a
You,
tenolysis, you
you heard
know?
it first on the upper hand. Breaking news. So I have a
Dr. Goldfarb,
question.
I think, is rolling his eyes right now in his
I'm seriously rolling my eyes. I don't know, but hey, I trust you, so I am gonna look for it.
again,
I,
it's experimental.
I have a question I want to ask you, but before I ask you that, I do want to thank our other sponsor, Checkpoint Surgical. So the upper hand is sponsored by Checkpoint Surgical, a provider of innovative solutions for peripheral nerve surgery. As a hand surgeon and as a hand therapist, you know that nerves matter. It's why Checkpoint Surgical is singularly focused on elevating the clinical practice of nerve surgery with innovative technologies that help improve patient outcomes.
That is quite a sentence. Checkpoint Surgical's portfolio includes a range of handheld, intraoperative nerve stimulators, nerve cutting instruments, and biomaterials. To learn more, visit www.checkpointsurgical.com. Checkpoint Surgical, driving innovation in nerve surgery.
There you go. There you go. And Checkpoint did exhibit and was a premier sponsor for our nerve course. So thank you to Checkpoint for supporting that. So Macy, the question I wanted to ask you is, as surgeons, after we've placed pins, would you prefer that we bend or not bend the K wires after they've exited the skin?
I don't really care.
Good answer.
Okay.
I've seen some
Whatever, whatever,
circumstances where I had,
whatever you want to do.
well, I don't know. Sometimes it gets the way that the pins are, positioned could get in the way of, wound care. And I clearly try to make a point to make sure it's not going to get in the way of any motion of the adjacent joints.
Yeah. The only thing I can think of is sometimes like the pin cap is really, if it's a thick one, if it goes in the web space, it drives them crazy and it's uncomfortable for splinting, and just at rest, it just kind of like rubs on them. But that's the only circumstance where I think it's the position is annoying, but you might not be able to like avoid that.
Presumably, for the index finger and the little finger, you would prefer the pens to exit on the radial side or ulnar side, respectively. I assume that's a big deal. You can't really control it with the middle and ring. Is that
Hmm.
fair?
Yes, that's fair.
Sometimes easier than others, but I think it's a goal.
Yeah. Yeah, that's fair.
Chuck, do you bend your pins? I can't remember now.
I do not bend my pens, and I
Okay.
use pen caps because they're inexpensive.
Right, right. And I sometimes bend pins and I use Jergens balls because they're slightly more expensive and to get underneath Chuck's skin. No, but I've had patients get kind of freaked out about the regular old pin caps just kind of falling off. So it's just one less phone call.
Mm.
Totally true. Macy, we're
Yes.
coming to a close. We got to know, what's your least favorite fracture to see? Is it a mallet fracture? Is it multiple phalangeal fractures? Are there
That's it. That's it right there. So multiple P1 fractures, whether it's 2, 3. P1 fractures are difficult in general, but when there's more than one, I find that that's a huge indications for a more difficult recovery, especially in an older patient.
Amen. I totally agree. And those patients get stiff, they get frustrated.
Hmm.
That's my least favorite scenario.
Can I ask you all a question? My multiple P1 experience has been colored by a number of dog leash injuries. I feel like those are the worst.
Mm.
Have those been a problem in, both of your practices in terms of, the mechanism is challenging, tons of swelling. They just seem to take longer.
I think it's true. Dog leash, people do not understand the dog leash danger. The
Hmm.
dog should come with a warning, like,
Hmm.
or the leashes should come with a warning. It happens all the time. It's like the equivalent of the trampoline for kids. It's
Yeah,
the dog
absolutely.
leash.
I'm thinking more about like fall or something like that, where that's where a lot of the cases I'm thinking of with multiple P1 fractures. But yeah, they're not fun.
Okay, and can I ask one last question, Macy?
Yes, of course.
If people have a dynamic external fixator, a Slade frame, so to say, do
Mm.
they actually move in therapy?
While I'm watching them and like telling them to do something, sure. But do they do it at home? Probably not, if that's what you're asking. Are you saying like, do they actually do the exercise, or is their joint actually moving?
Well, we call it a dynamic X-fix, and I feel like it's much less dynamic and more of a static X-fix for a lot of people. It's almost like, honestly, it's like one of the fellows' favorite procedures to indicate when they come through. And then after having done it a few times, I've just been not impressed with their ability to move. Now, ultimately, they do as good as any of these patients can do, I think. But I just don't
Yeah.
think they're moving a whole lot while you've taken the very high amount of time to put together that erector set with the rubber bands.
I have a relatively recent case from Dr. Brogan, and he did great. He had a DPC of like 1 or less, negative 10 degrees of extension at the end. Did great, super swollen, and his PIP joint is always, I think, going to be somewhat enlarged compared to the other ones. But he was like 17 and healthy. But again, an older patient, I think that they would have like some chronic stiffness for sure.
I guess I'm sending all those to Dr. Bergen.
That's exactly right. He enjoys them. He enjoys them. Macy, thank you as always. That was great, educational for us and hopefully for our listeners.
Yeah, thank you so much for having me.
All right, till next time.
Good night.